Yeah, so first of all, I would like to uh, congratulate and thank the previous two speakers, Dr. Chetan Deshmukh and Dr. Alok Goel, who have covered the topic very beautifully and illustratively and made my job much easier. And so I now only have to try to get a consensus on the various topics. So my first question will be to Dr. Pankaj Goel. Uh, uh, so do you agree with this NCCN list of high emetic drug list, or do you think any drugs like, for example, carboplatin should be considered only moderately emetogenic?
So I think by personal experience, I feel the carboplatin is not that much equivalent as we see anthracycline and cyclophosphamide. So probably there needs to be a bit of readjustment in the drug list, whatever we read since ages.
Yeah, yeah. Dr. Ankur Vashti, do you agree with this comment, or do you think carboplatin UC4 should be considered highly emetogenic only? Can Dr. Sharat Chand, can you please take this question?
Yeah, I think I agree with Dr. Pankaj Goel, sir. In our daily practice, carboplatin more than 4, in fact, more than 5 is also not that highly emetogenic is what I have observed. But then when uh, added with paclitaxel, some patients do experience, but then the overall percentage, I would rate it as a moderately emetogenic, at least in my practice.
Yeah, when I feel so. So we'll go to the next question. So as this slide has been shown multiple times in the previous two talks. So Dr. Shantanu, would you agree with the 4-drug regimen for highly metogenic chemotherapy, or you feel a 3-drug regimen is enough? I think is not it. Dr. Pankaj Goel, can you please take this
So
question?
I think when we talk about AC, a four-drug
Yes.
regimen will be definitely better.
Yeah.
Barring AC, if we talk about the other options, we may do very well, I think, with three drugs as well. But if we talk about AC, this is one of the most hematogenic regimen. Or if you're using cisplatin in a higher doses, then probably those are the cases in which we can probably prefer to use a four-drug regimen.
Okay. And for carboplatin, do you think this 3-drug regimen is okay?
Yeah,
Or
that's what.
can you skip NQ?
Carboplatin, I think three-drug regimen will be more than enough.
Uh, uh, do you always give NK1 receptor antagonist, or do you sometimes avoid it?
Some now not to all patients, depending upon affordability, depending upon the previous history. Sometimes I do omit in the subsequent cycles.
Okay, okay. Uh, Dr. Sharat Chandra, do you agree with the comments, or you have anything else to add?
Nay, before I started using NEPA, my regimen was always 4-drug, and my results were better when I was using olanzapine. But the NK1 receptor was always either an oral aprepitant or posaprepitant. But then after NEPA, I was omitting olanzapine, and my the 3-drug regimen would equally suffice with the 4-drug regimen, uh, which I told you. So that is my experience.
Okay, okay. So are Dr. Ankur and Dr. Shantanu, any of you are you available for comment? Okay, okay. Meanwhile, Dr. Pankaj Goel, for the other moderately emetogenic drugs, you feel 3-drug regimen is okay, or we need to use only 2-drug regimen?
Yeah, so routinely what we are using is three-drug regimen. So they are very like if we are using single agent weekly paclitaxel, then probably I'll go for a two-drug regime. Otherwise, most of it is a three-drug regime, and for highly emetogenic, it will be a four-drug regime.
Since you are using olanzapine, so how is your
Yeah.
experience with it compared to the sedation? And do you use the 10 mg dose, or do you use the 5 mg dose?
So I prefer to use a 5 mg dose, and there's not much of a sedation if you're using a HS dose. So I think that really adds up. I've seen the patients if they are having experiencing nausea in the previous cycles, we use olanzapine in the next cycle, then that definitely
Yeah.
helps.
Okay. So, Dr. Sharad Chandra, for the low emetogenic category drugs, which of these single drugs do you prefer as an prophylaxis?
Low emetogenic, my choice would be a single agent 5-HT3 receptor antagonist, or sometimes only DEXA, and that is my usual practice.
Okay. And for the moderately emetogenic, do you prefer the 2-drug or the 3-drug?
Most of the times, if I'm using 5-HT3 receptor antagonist, then it is either along with DEXA, or sometimes I just use olanzapine and omit DEXA. So mostly it is two drugs. Sometimes I use a three-drug regimen uh, as per the patient.
Okay, okay. So I think we have quite a fair consensus that for the highly hematogenic group, particularly the AC and the cisplatin more than 75 milligram per meter square, the 4-drug regimen is better. And for the carboplatin, although there is controversy regarding being in the moderately or highly hematogenic, but the 3-drug regimen is uh, uh, quite acceptable. And for the other moderate hematogenic drugs, 2-drug or 3-drug regimen may be used as appropriate. And for the lower hematogenic category, a single drug is sufficient. So, Dr. Pankaj, have you used this NEPA combination, and how is it your experience with these factors?
So I have added this NEPA, especially so in the young patients when you are using highly hematogenic drugs. So especially when we are addressing these patients, like most commonly see this with the AC drug regime. Then if the patient is young, then I preferably use it, telling them that it will be an effective drug since the cost is a bit high. So we have to just talk to the patient before we start this drug. Patients should not feel that the chemotherapy drug is cheaper and the antibiotic drug has gone costly.
Yeah.
So, but definitely, yes, there are patients who will agree to this combination when we discuss, and it's really effective.
Okay. And Dr. Sharath, do you have experience with the NEPA?
Yeah, with NEPA, nausea and vomitings are very well controlled. What I have observed is it causes a lot of constipation also, which sometimes is bothersome. But then most patients are happy with NEPA.
Okay. And I have a very less experience with NEPA, and in those patients, the vomiting and nausea are quite well controlled.
The first patient I put on NEPA, the patient vomited the drug. So
Okay.
after that, we are a bit skeptical. Yeah.
So, Chetan sir, how is your experience with NEPA, and for which patients do you consider this combination?
NEPA I use only in patients where I'm going to give chemotherapy over 3 to 5 days because it makes life easy. You give palonocetron only one day. So for single day chemotherapy is hematogenic, highly hematogenic, or even moderately hematogenic. We still have not. I don't have a lot of experience with palonocetron. We still prefer to continue with the previous 5-HT3 inhibitor. To be very honest, most of these things are often done even before we actually see the patient. A lot of antiemetic orders and a lot of antiemetic prescriptions are given by the time we reach them, the pre-medication has already started. I don't know what is the experience with other panelists, but by the time you actually go for rounds before your and you start your chemotherapy, pre-medication usually has started at the resident level. So
Yes.
we have off late only after attending these meetings and reading more about it. I also had a presentation on similar lines in another meeting, that we realize that transaminitis is a major side effect of these drugs, and we are using these drugs quite rampantly. Even after chemotherapy, a lot of 5-HT3 antagonists are prescribed. So we somehow I feel that we need to be a little more judicious about the use of antiemetics.
Yeah, definitely, I guess as you told that the number of drugs is not much, but the judiciousness and innovativeness lies in the sequence and the way they are being used. Dr. Shantanu, so how many of your patients do you feel have a serious like this fluid and electrolyte imbalance after MSS due to chemotherapy?
Sorry, come again? Can I not?
Dr. Shantanu, this question
Yes.
displayed on the screen. So,
Yeah.
what proportion of your patients have these fluid and electrolyte imbalances or other complications due to MSS following chemotherapy?
Be around 5%, 5 to 10%, less than 10 mostly.
And do they require admission, or they can manage
Most
on
of the
a different
patients
basis?
don't really require admission. It is manageable, but it is distressing to the patients.
Yeah, yeah. So again, since we are discussing NEPA, so as was shown in the study, so NEPA has better than the 3-day aprepitant. So Dr. Pankaj, do you prefer it over the 3-day aprepitant combination
So I think this,
in case there is no cost issues.
yeah, this NEPA is, I think, better as far as the efficacy is concerned. And moreover, when we give this 3 days every patient, most of the patient will not be actually knowing that they have to take the tablet on say day 2 and day 3 if the sister is not told properly. So that is also an issue that you also have to be careful if you address these patients with every NEPA, those issues are not there. So I feel that is a bit more effective than the previous regime.
Yeah, definitely. Compliance of the appropriate day 2 and 3 remains an issue many times. Patient and they are not explained and they usually miss it. So definitely that is it is better. So regarding DEXA sparing regimens, so Dr. Sharad, can so so can we consider DEXA sparing effect of a potential NEPA in our practice? In which patient subset do you use this DEXA sparing regimens? In which category of patients?
I think with the results shown by the previous two speakers, it was very encouraging in a few subset of patients, maybe in an immunocompromised or badly managed diabetes. Maybe I would prefer this DEXA sparing regimen where I would use a NEPA and go ahead. The patients which I would maybe use is like I told you, the immunocompromised patients or the immunosuppressed patients or the ones who are badly managed diabetes or something like that.
Okay. Any other regimen apart from NEPA which you would like to use for the DEXA sparing effect?
Maybe if I'm using an olanzapine based regimen and then KST3 receptor antagonist, I would prefer that regimen as well.
Okay. So Chetan sir, what is your take on this? Which patients need DEXA sparing regimens, and which is your preferred DEXA sparing regimen in these patients?
Honestly, I have never used a DEXA sparing regimen. But the data looks very tempting, especially that the other trial where they have given a single dose of DEXA, maybe with netipetant and palonosetron combination on day 1 and DEXA alone on day 1, and for the remaining 3 days of or 5 days of chemotherapy, we don't give any dexamethasone. That sounds like a good bet. But honestly, my experience has been none. I've never tried it. But nevertheless, it is very appealing to use it.
Yes, sir. Since we know that dexamethasone is quite the backbone of antiemetic therapy, so sparing it, we very rarely stop it. Only in some patients with uncontrolled diabetes and other immunocompromised patients. So, Dr. Shantanu, your take on this? Dr. Shantanu?
Dr. Shrikant also join us now.
Yeah,
Dr.
I have joined.
So, your take on the DEXA sparing need for DEXA sparing antibiotic regimens, and which regimen do you prefer?
Yeah, if DEXA sparing regimens are there, then I would like to prefer olanzapine based regimens. That would be better. Yeah, and Nupitant can also be tried. If like NK1 agents could also be tried in DEXA sparing as a DEXA sparing agents.
Okay. Dr. Pankaj, do you have anything to add in this on this topic and the DEXA sparing?
Quite a number of patients are there in which actually I am not able to use dexamethasone, like the patient has just recovered from sepsis, or the patient is having say severe electrolyte imbalance, or the patient is having a problem of severe weight gain over past 3-4 cycles. Then there are very few patients in which I do omit DEXA. Like if I am using paclitaxel, I may use the other regimen, the Aqualip, the Pacli-Aqualip, in which we actually do not need steroid for the reaction. Or maybe you're using carboplatin, then I omit DEXA. In those patients, I use a NEPA-based antiemetic regimen. And in my experience, there were not much of a difference when you are careful in moderate emetogenic regimes, when you're omitting DEXA and using a NEPA-based treatment.
Definitely, I guess so. We have a consensus that in some of the patients, DEXA sparing regimens are required, and this netipetant-based day 1 DEXA sparing Dexa is an option along with the olanzapine based option, but the experience with this is less, but the data is appealing and we may try it. Chetan sir, any final comments?
No, I think most of the points have been discussed thoroughly. I agree that Dexa sparing is something which we need to give a thought, and probably it's just our mindset that we are still stuck with Dexa. If we have a good combination like netopitant with palonosetron with olanzapine, I think we should be able to cut down Dexa in some of our patients. But again, this combination for multi-days chemotherapy sounds like a good bet. And I would just like to reiterate the side effect profile of these anti-emetic drugs should not be neglected at all.
I definitely agree, sir. So, any of the panelists have any final comments? If not, then we can.
There's a question in the chat box. Can you just take that?
So the question is whether would we consider 3 drugs for oxali or irinotecan based regimens, and are those sufficient for those regimes? And second question is, would you add carbo, oxali, irinotecan in 60 to 90 high moderate group? Dr. Pankaj, would you answer the first question? 3 drugs for the moderately emetogenic oxali or irino based combination regimes?
I think it's disconnected.
Yeah. So I think Dr. Sharath?
A 3-drug regimen would suffice for oxali or irinotecan based regimen, in my practice. Never used a 4-drug regimen for these patients. In fact, 2-drug would also suffice, but 3-drug would be even more comfortable.
Okay, Dr. Annie, your take on this 3-drug regimen for oxali based chemotherapy?
Yeah, 3-drug regimen can be used and it is feasible. Yeah.
Yeah, I think so. I mean, I feel that the 3-drug regimen is better for the moderately emetogenic category of auxiliary or irinotecan based regimens. And second question, whether the carbo, auxiliary or irinotecan in the 60 to 90% high moderate group. So Chetan sir, do you think this group should be in the high moderate group, or whether it's the bigger category of moderate is enough for will encompass all these drugs?
Do you mean irinotecan with carboplatin?
So I'm not sure the question. Dr. Oswal sir, are you there?
So this thought process of being carbo oxali or ino being high moderate kind of regime, and the thought process and the discussion is going on that we should consider these regimes into high moderate, where we definitely need and maybe more. So is there any so carbo is already being considered kind of that kind of drug. So do we have any consensus on that? Any opinion of the moderator or the panelists? Or are you happy just consider this part of moderate hematogenic group and continue with 2-drug or 3-drug as and when it comes?
Sir, it should be considered as a highly emetogenic combination, because having said single agent carbo along with carbo when added to oxali and irino would definitely be in high risk for emetogenesis, sir.
I think for carbo it is quite clear that it is in the high moderate, but for oxali and irinotecan I feel that they're still in the moderate only, and as required 2 and 3-drug regimens may be used.
Okay, this is a couple of papers and this Japanese data on oxaliplatin, a randomized trial looking at 3-drug combination versus 2-drug with oxali based regime, and based on that, and as our experience with oxali definitely causes by and large a lot of nausea, vomiting, in spite of even we have actually changed from practice from 2-drug to 3 drugs. And that's the reason I asked that question, whether even 3 drugs are sufficient or you need to add more.
Yeah, and as the oxide is known for causing delayed vomiting, so definitely 3-drug regimen will be a good option for this regimens. So if there are no other questions,
Thank you.
Yeah, thank you. So if there are no other questions, we can close this session.